well, icebreaker response. I don't really have an icebreaker for us today. So if I could just get your name and pronouns and the organization that you're a part of in the Zoom chat.
Well, let's think of one. I want to hear people's voice. So if you don't mind me jumping in, I would say, and I'll be self-serving because my garden is getting ready to explode, but what is a flower or a vegetable that's particularly fun for you during the summer months? And I'll just start by saying, and I guess, I don't know, I'm probably blowing the whole agenda because, but we have a small group, so I'd love to hear people's voice. Is that okay, Rosemary?
Yeah, that's totally fine.
Who's very sweet. And so I would say I love my dinner plate dahlias. They are really, really big and really awesome, and I love giving them to people. So maybe quickly just pop in and we'll do it this way. So I'll go to Isaac. What's a garden thing that you like, flower or vegetable?
I like a lot of more kind of like wildflower type, like bushes and wildflowers. So I don't, know like the technical names for all of them, but I like a lot of those like tall grasses that kind of have like the feathery look on the end. I think those are really cool.
Cool. Please call on someone.
All right, I'll pass it off here to Lori.
Thank you, Isaac. Hi, everybody. Well, I'm not a gardener, but I do have a fabulous app that is like a plant identifier. So I can identify things and I try to remember them. But I think, and the season is now coming to an end, but one of my favorite things are the Washington strawberries. So I love those. And I'll pass to Ashley.
Hello, everyone. I am Ashley Mangum, and I am the Director for Kids Mental Health Pierce County, and also providing support for the Youth Regional Behavioral Health Navigator Program. And Jim, you asked me about two things I really don't know anything about: plants and vegetables. So anything in the wilderness I can appreciate from afar. So I'll turn it over to Daniel.
Thank you, Ashley. Hi, everyone. My name is Daniel Lugo. I use he, him pronouns, and I am Treehouse's Manager of Policy and Government Relations. I think that I'll say avocados. I just like eating an avocado in the summer. Something about it is just so good. So I will say that. And I will pass it off to Tatiana.
Hi, I'm Tatiana. I'm the Youth Department Site Lead for Serenity House of Clallam County. And I would say for summer, I really like salal berries. And I will pass it to Erin.
Hi, I'm Erin Hathaway, she, her pronouns, and I would say I really like lilacs and wild lilacs, both of which have kind of come and gone already in my garden, but they smell amazing. I will pass it to Nicole.
I am Nicole Murphy, occupational nurse consultant at the Healthcare Authority, working on House Bill 1905. And I have a garden. I could talk garden all day long, but I love things that grow from when I look at it one moment to when I look at it the next moment. So peas are one of my favorite because they grow so fast and I can trellis them and put them where I want. And I will pass this to Rachel.
Hi, Rachel Baxter. I'm a behavioral health stable housing policy lead for transitional aged youth at Healthcare Authority. I can't garden. I kill things. But I would say my favorite flower is a dahlia as well. And I also really like berry bushes. And I will pass to, let's see, V.
No, V's here. Good.
Yeah. Hey everybody. So sorry, my Wi-Fi cut off on me. So for 10 minutes. Yeah, anyways, I'm sorry. What's the question?
What's a flower or vegetable from the garden that you like?
Oh, okay, let me see. Cherry tomatoes. They are so good. They're really sweet. I used to hate tomatoes, but now it's so good. All right. Has anybody gone, or was I the last one?
I can go.
Hi.
I'll go. I'm sorry. I thought I was cutting someone off. My name is Vanessa. I'm program coordinator, Kids Mental Health, Pierce County. And I was going to say dahlias, but so I would say dahlias for a flower and corn on the cob for, and it's a starch, but it's kind of a vegetable. And it's just so good in the summer. It's so fresh and delicious. So that's going to be mine. And I'll go Gina.
Thanks, Vanessa. I'm Gina Capadou. I use she, her pronouns, and I'm a program coordinator with Kids Mental Health Pierce County, also working with the Washington Youth Regional Behavioral Health Navigator Program. Yes, it'd be a lot to fit on a business card. I would have to say, I'll diverge a little bit and say watermelon. I love me some watermelon because I too have a black thumb. I can't grow anything.
Hi, everyone. This is Janice Schutz, and I'm sorry both that I'm late and that I have to be off camera. I am in an internet unstable area. I'm the executive director of Washington State Community Connectors, which is a statewide family-run organization supporting families raising children using behavioral health services in Washington State. And that's a mouthful too. I love all plants, fruits, vegetables. I love the summer season here where we can get everything fresh. I too am a poor gardener, so I rely on others. And strawberries and raspberries are probably my two favorites.
Is there anyone who hasn't listed off their favorite thing to grow? Awesome. Now, V, would you like to go into the scope and mission of the Bridge program?
Yeah, for sure. Hey, everybody. So, our focus for the bridge is to, how do I say this? Right. So, a lot of young people exiting inpatient, specifically within 3 months, would return back to homelessness. And data shows that, well, how do I say this? I'm so sorry. Yes, our focus is on this. Oh. Hello, can anybody hear me?
Mm-hmm.
Hello.
Yeah, please continue.
Hello.
Yeah, we can hear you, V.
Oh. Okay, I'm so sorry. It cut off for a second.
If I can continue off of your point, V, I'm looking at the flyer for the Bridge program right now, and the most recent data available shows that about 75% of young people exiting a Washington state system of care, that's foster care, criminal justice, and behavioral health, experience homelessness within 12 months of their discharge. Oh, I'm sorry, I misspoke. Who experience homelessness within 12 months of their discharge left inpatient behavioral health programs. So the need for supportive services after a person leaves inpatient is pretty high. Now, if people are open to it, I would like us to move on to a just time to reflect and discuss on why this is a program that would be helpful and necessary for people leaving inpatient.
So Rosemary, I'm going to jump in. I don't know if your agenda shows it, but I want to say a couple things before we move into this and kind of set it up. So, but yeah, I just want to make sure folks understand the mission, and V's having trouble with her internet. But the bridge, this is our 6th month. We got a contract that started in January with the Healthcare Authority. And it really was based on the data that Rosemary and V both referred to, that of all the young people coming out of systems of care, and Rosemary identified what those were: foster care, juvenile justice, and inpatient behavioral health. Young people coming out of inpatient behavioral health were most likely to be homeless within 3 to 12 months, with a very high number at 3 months. And when I was at Away Home Washington, we actually produced the first report that identified this using DSHS RDA data, Research and Development Administration. But it's data that comes really directly from young people and their experience exiting a system. Being a clinician at heart, and that's been mostly my career before I got into advocacy and running organizations, it broke my heart to think of young people saying, yes, I'll go inpatient and get treatment, and then they're discharged back to an encampment or they're discharged to a drop-in center that has no beds. We also know that that's not because that's what discharge planners want. They don't wake up saying, how can I have a crummy discharge plan? But it's a lot of factors of not knowing what the resources are, many of them not used to serving 18 to 24-year-olds, mostly an older population, and not having enough resources. So the bridge is trying to both do some cross-system collaboration, so the community social service agencies and community housers are connecting with inpatient discharge planners, and just do some cross-system relationship building. The second is wanting to really build what we're calling a return to community plan rather than a discharge plan, because in the experience that I have, and I think others, when you have a return to community plan, and some could say that's just a cute little name, but for us, it also implies more than an address. It implies what resources does this young person need to get to their treatment program, what relationships are in that community. But at the heart of it, it's also, does the young person have some agency, some say in customizing this plan? And so we really hope to be talking to young people that are at risk of being discharged without a strong plan, really asking them, what do you want? Where do you want to live? Who could you live with? Where would you be that would support your healing and your sobriety? And then the third is deliverable for the bridge is making recommendations to the Healthcare Authority around proposed legislation or budget items or practices. And I think return to community is an example of a practice. But what can we recommend based on what we're hearing from you all? That they might put in contracts, we might make in legislation, et cetera, et cetera. And again, Rachel put in our our meeting guidelines or rules of the road. But what we thought, since today is our last meeting of the first contract, and I'm happy to report that because of the participation we've gotten, we are in process with Rachel Baxter, our Healthcare Authority contract person and co-conspirator in all of this work. We're getting ready to sign a new contract that covers the next 2 years. And so for us, this is really exciting that we know we've got 2 years of funding to build on. And so Rosemary will tee it up, but we thought, given this is the last meeting of the first contract and before we start the next contract period, we really want to hear your thoughts about any or all of these. And we've got some questions that we all worked hard on. So I'll just turn it back to Rosemary, but thank you in advance for really being active thought partners on this. We really do want to make sure we're creating an environment that's worth your time, is valuable, that we can help shape the system. That's the North Star. When I came up with that name, it really was not just how do we plug a hole today, but where do we want these systems to be 1 year, 3 years, 5 years from now? Thank you for that time. And Rosemary, I'll turn it back to you.
Yeah, it's really exciting to know that we have more time to build on this program and turn it into a system that really supports people in a way that they aren't being supported currently. Like I said earlier, I want to open up the floor for people to talk about the current state of behavioral health services and more specifically what your region could use in their behavioral health services. To start us off, my experience of behavioral health, I have worked in adult and children's inpatient, and both have been places where I had to see residents go back out onto the street rather than being safely put in a home or safely transferred to a situation that actually supports them and supports their mental health needs. And I've seen a lot of residents go really downhill after that. Is there anyone who would like to talk about their experience with mental health services?
Janice has her hand up.
Oh, okay, Janice.
Thank you. So I am here kind of representing the family community of youth being served. And I can say that this has been a big concern for families, not just in discharge home to families, but sometimes there are youth who are discharged to their families and it's actually not safe for them to be back in their family's home for other family members. And that is a real pickle for people because it ends up being a tug of war. And I just wanted to say that I hope that's something that through this program possibly can be looked into and addressed. And then as a new person to be here at this meeting, I've been hearing about it for a while, and this is the first month I could actually get here. So I'm glad to finally be here to learn. And I was wondering if there are any new interventions that you have tried or put in place so far that have been beneficial.
Well, Janice, thank you for being here. And I will say in my private practice, I do a fair amount of work with families and young people who are in the situation you're talking about. It's a failure on my part that I didn't clarify that the bridge is really focused on young people facing unaccompanied homelessness. So those that do not have an active family, some of them, my experience is after they come out of treatment and they're clean for 3 months or on their meds for a while, the family is more than willing to kind of come back. So it's not that they're not loved, but they are unaccompanied. I do hope, though, that the bridge can take some of that on. But for now, the scope and what our contract really is those who are kind of doing life without an active family. But I hope that doesn't dissuade you. And in terms of some customized planning and some interventions, I'd be happy to talk to you. I don't know that they're new or magical, but again, I have a private practice of a handful of families that we've tried to do some different things that keeps everybody safe, but also kind of accepts where people are at, but also moves it forward so that young people can hopefully live at home. That's not always the case, as you know. But I wanted to clarify that, and I should have said it earlier. It's really unaccompanied homelessness.
Absolutely. Thank you for that clarification. And I am just, happy to know that there's work being done to help all people using services who exit into homelessness, because that's really a problem area, as you know. That's why we're here.
I'm happy to jump in and hopefully my comment doesn't derail the conversation in a way that facilitators don't want. So if that ends up being the case, feel free to correct me and redirect the conversation, but I'm just curious as far as like, Jim, your comments earlier about dischargers, just letting young people go back to like homelessness encampments and whatnot. I think we can all appreciate that inpatient dischargers don't want to do that. And so the next question that I come to is, well, what resources do they have available to them? And if we are to make recommendations to the healthcare authority to improve the outcomes for these young people, the first thing that comes to my mind is a liaison of sorts within the healthcare authority that the dischargers could contact when they kind of face a barrier like, oh, this young person's about to exit. We don't know where they're going to go. The outcome is going to be homelessness. And so if they go to the healthcare authority and there's a liaison who maybe can help facilitate service identification, whether that be reaching out to their colleagues in like DSHS, perhaps DCYF. And then I'm always a fan of flex funds too. So if the healthcare authority has like a pool of flexible funds that they could tap into if there are not adequate resources that will prevent homelessness, I think that might be a good way to do it. Although I do know at the same time that flex funds are very popular. So I could see why the legislature, like they hear flex fund all the time, right? They don't want to have a million different flex funds. So, but those are just the thoughts that I have right now.
I really like that feedback. I do think, this is Rachel from HCA. So currently, as it stands, discharge planners or even hospital staff or inpatient staff do have to contact their MCO 24 hours prior to being released or exited into unstable or unsafe housing. Those MCOs should also be reaching out to HCA to notify if there are concerns and they're not able to find safe or stable housing, that they should be reaching out to HCA, managed care organizations. So their insurance company should be reaching out. And that is if they do have a managed care organization and it's not a private insurance, but I'm sure a private insurance does also have care coordination. I'm not sure about that, to be honest. But I would say also that at HCA, if anybody ever needed to contact myself, I can also be utilized as a liaison. I do technical assistance to try to find resources and safe places for individuals to go. And then I was going to touch on what Isaac had placed in the chat as well, that Away Home Washington also does have flex funding available for individuals that are unsafe or unstably housed. So I think that
I guess like my follow-up question to that then is like, what's the issue? Like, why aren't these resources being utilized?
So the 6560, 1905, and 1860, so all of the programs like the bridge that are being funded were created as of last fall. Is really when the program started. For Away Home Washington, I can't speak to that, but I will say that the training has really just been started in the last probably 9 months. And so MCOs and community members have definitely been receiving training and do have access to those funds. And anyone is also able to do that training as well. Maybe Isaac, if you want to touch base on that real quick.
Yeah, I'd love to. So for context for folks on the call, I'm actually our fiscal admin for the Youth Diversion Infrastructure Project here in Spokane, and also the Youth Homelessness Prevention and Diversion Fund, both of which are pools of flex funds. The Youth Diversion Infrastructure Project, excuse me, the Youth Diversion Infrastructure Project can be used for anyone under the age of 25 that is either exiting a system of care, so child welfare, inpatient treatment, or juvenile justice or adult justice, exiting a system of care and at risk of discharging into homelessness, or has previous experience with a system of care and is currently experiencing some form of homelessness or housing instability. So pretty broad, and the money can be used for anything that's directly tied to housing. What we see a lot of is, paying for move-in costs or relocation, or what we like to call in the field is like informal host homes. So if they have someone they can stay with, but finances are a barrier, we can pay a lump sum up front. The Youth Homelessness Prevention and Diversion Fund is very, very similar, except folks don't need to have any system of care experience. So it's just any young person who's unaccompanied between the ages of 12 and 24 that can access that specific fund. But as Rachel said, YDIP is pretty new. Trainings actually didn't start till about February this year. So just in the last four or five-ish months. In Spokane, we actually have almost 100 providers already certified in the fund. And other communities have quite a bit as well. But like I put in the chat, YDIP right now is just in Clark, Spokane, Yakima, Walla Walla, and Pierce. HPDF is also in all of those same counties, but it's also in Clallam, Jefferson, and I'm missing a couple, but it's in 4 more communities than YDIP.
That sounds really promising. And I think that might be a good recommendation from the bridge, is that we support the growth of it and just monitor the impacts of it. I do wonder like how that would overcome issues like, for example, credit scores. Like if you need help moving into an apartment, but a landlord doesn't want to even accept the down payment because your credit isn't to their standards. Like, I wonder if there's like potential legislation that could follow up that like would give organizations like YDIP like co-signing authority or something like that, so that landlords can't keep up those barriers. Just trying to think creatively, right?
Yeah. I'm going to pull this up a little bit because I think we're and I know we've got some poll questions we want to ask. But I will say, to your point about what's the problem, Daniel, I think part of it that I continue to realize is just how complex this system is, particularly with insurance companies. So it may be that the insurance company says Jim's got to leave the hospital tomorrow, or and so the inpatient provider is kind of surprised by how fast that discharge process happens. I know we talk a lot, and I worked at Harborview 30 years ago, and we talked about discharge planning starts the day the person comes in, and that's true, a good kind of principle. But when you're understaffed and lots of crisis going on, that doesn't happen in the way that we would want. So I just think that's part of it, and that's what the bridge hopes to do, is this cross-system relationship building and training. But there are some good solutions out there, and I'm going to ask Gina, if you wouldn't mind just saying a couple paragraphs. We're going to invite you back to do a training, but I think Kids Mental Health Pierce County, which is now going statewide, is a good example of something that I've come across that I do have hope in how they're doing this work. Ashley as well, maybe it's Ashley or Gina, but maybe just a couple paragraphs to wet our whistle about what y'all do, and then we'll invite you back for more time.
Yeah, absolutely. And I absolutely encourage Ashley and Vanessa to jump in and support anything that I might be missing. So the Kids Mental Health Pierce County program has a framework of a couple of things, and it's really expanding across the state, as Jim said, as the Washington Youth Regional Behavioral Health Navigator program. So those components, and of course it's going to look different in every community, are spread across the 10 behavioral health admin service organizations. So I'll make sure I drop our website in the chat, but there's these 10 regions that kind of divide up the whole state. And so we work to bring some of the framework model pieces of Kids Mental Health Pierce County to each of these regions. Each of these regions will have 3 behavioral health navigator team members. So there's going to be 2 care coordinators and then a manager. And what each of those regions do with those teams is they really focus on kids' mental health. Predominantly, that means for kindergarten through 12th grade. And what they're implementing is a regional website that has all the behavioral health providers, services, and organizations in one spot that is continuously kept current. One of the things that our team loves to say is that families tell us all the time that they don't need another doorway to an empty room. So having that current resource list available through that website is really important. It's designed to be intentionally interactive and useful for the families while they're navigating it. A second thing that we bring is the multidisciplinary team meetings. We bring a variety of different partners together on a call, and that includes everybody from the families and the youth themselves. That's a really central part of scheduling that meeting. We also bring in behavioral health providers. We bring in hospital staff. We work with really just any supports that the family has. That can be church members, it can be schools, it can be the juvenile justice system. So it's really a multi-system framework. And we make recommendations in that meeting of what are some resources that could be used to support families. And that's everything from behavior management strategies to even applying for and going to the CLIP process, which we all know that there's at least a 6-month wait list, if not more, if you're approved to get into those programs. So really the MDTs focus on what can we provide with the resources and relationships we have now. And some of those resources are clinical, some of them are not clinical. And then I think the third piece that we really bring as an emphasis of this model is a steering committee that brings all those multidisciplinary partners together. I think so often that the systems and the people working in them are trying their best to serve families, but no single system can provide all the services that a family and their community needs. So by working together to streamline those initiatives, we're going to be much more effective. So those are some of the key pieces. To close off my last few paragraphs, Jim, to your point, is currently, of course, we're in kids mental health in Pierce County. The first 3 regions that stood this up starting in July of 2022 was Greater Columbia, Salish, and then our friends in Southwest. But we're very excited that within about a week, we've got our next 4 regions that are joining. It was supposed to be 3, but now it's 4. That's going to be our Thurston Mason area, Great Rivers area, North Central, and then Spokane. The very last 2 regions will launch July of 2025, and that's going to be that King County and that North Sound area. So I'll drop all of that into the chat, but I think what's really important to us throughout the entire model is it's going to look different for each region, but it's really centralized on what is the family experience and what can all of us do with the resources we have, and then build the paint the picture of what don't we have, what has worked in other places, and how do we tell the story through data and also through narrative.
Awesome. Thank you, Gina. Now I want to give some time to Lori, who's had her hand up for a while. And after that, we'll be moving over to Erin Hathaway with some poll questions.
Thank you, Rosemary. Just quickly, I want to go back to something, Rachel, it might have been you from the Healthcare Authority, about what the MCOs are supposed to do. And I just am very curious if there's a way, do either the Healthcare Authority or do you know if the MCOs do any kind of follow-up or feedback mechanism or anything to see what the actual experience has been for the individual or the family, but likely the individual when they are being discharged? Because I have to admit some skepticism about sometimes what a carrier will say they do versus what is really happening. And I know enough to know that the relationship between the MCOs and the Healthcare Authority is kind of complicated and confusing at times, because we see the Healthcare Authority as the overseeing body, but there are many things that I know are really under the control of the MCO. So yeah, so I'm just curious, when there is the notification that a person is leaving one way or the other, and they're supposed to be doing something within that 24-hour period, how do we know what truly is happening? And is there any way to find that out?
So that's actually something we are working on currently. I wouldn't say it's based on an individual's feedback. I would say it's based off of what the MCOs are reporting. And with that, just as you stated, we do know that there is some gaps that need to be filled, that the data is not capturing well enough. So that is going to be, Nicole is on here as well. And those are things that Nicole and I are both looking at as to how we can capture that information. We do have some work groups that are also reviewing that information specifically for transitional aged youth. Nicole, is there anything that you can add on that?
Yeah,
I feel like I
I
didn't give a very great
Yeah,
answer.
I would just say that the managed care organizations are responsible for care coordination. So connecting to services, including housing, and any other needs that that individual may have. So the MCOs should be reaching out to either the patient or the client themselves or the discharge coordinator to do an assessment to sort of see what the needs are. And HCA, I've been working recently on a project of an escalation process so that there are clear ways for escalations to come to us if needed. But in general, the managed care organizations should be the ones reaching out to that individual or the discharge coordinator to make sure that services are put in place and that there is a plan for that individual to be discharged with services or connection to services and things like that. So and the managed care organizations are also, they have meetings as well with like DDA and home and community services and foundational community supports. And so there is connections there as well to just make sure that if assessments from other agencies need to be done, that those can get set up as well.
Thank
Nicole.
you. Oh, go ahead, Rachel. Sorry.
Just I just want to speak on the question that Lori had asked regarding the data though. Do you know of any other ways we are collecting individual data or a way for families to report their experiences? Would that just go through the MCOs themselves, or is there a way that we can receive it?
Healthcare Authority can request data, but I don't know specifically how the MCOs are capturing or collecting data on that. I do know that if a care coordinator or a case manager has any open cases or something has been assigned to a care coordinator, they are collecting the data as far as what the need was and if it's been met, because they should not be closing any cases unless those needs are met or they're unable to contact that individual. So we can request the data from the MCOs if we need it. We just have to be specific on our ask.
Well, it does kind of seem to me like some accountability would be good for particularly when people continue to identify that there's a big problem with people leaving inpatient behavioral health programs and going into homelessness. And it sounds like the MCOs should be doing whatever they possibly can to make sure that doesn't happen. And if it is still happening, that would be really good to know, but it kind of seems to me like we don't really know. So if anybody has thoughts about how we can really get that, and it's tough when you're relying on the entity to provide the information and that entity is the one you're trying to make sure is doing what they're doing. It's all kind of weird. But anyway, I'll stop. I just would love to see there be a way for us to have a true sense of how many people, what's happening to the individuals when that 24-hour notice is happening, or like Jim was saying, start the discharge planning much earlier, what's really happening and what are the MCOs, quick care coordinators running into in terms of barriers themselves.
What
Thank you.
earlier Jim mentioned that.
I'm sorry, Daniel, but or not Rachel. Erin has those poll questions, and I really wanted to get into that before we continue.
I couldn't find my unmute button. All right. Well, this seems like a really rich discussion. I think we can come back to it in some of our discussion prompts here too. So hold on to your thoughts about MCOs and their role in this whole complex system. What we're going to do, we have a series of questions that we wanted to ask for capturing some of these reflections. So I'll launch them when Rosemary prompts us here. I'll leave the poll on the screen for as long as it takes to get a decent number of responses. You should see real-time information. And then Rosemary will ask folks to just sort of unmute and share your thoughts to elaborate if you have any. So let us start. We just want to get a sense of your roles. Many of you, I think, know each other and know each other's work, but if you could just select yes or no to which of these types of service provision your organization may provide. And is everybody able to see real-time information appearing here?
Yeah.
Great. So it looks like we've got a lot of people who serve youth and young adults experiencing or at risk of homelessness. Majority of the group. More people do not make referrals for inpatient treatment than do. That even on referrals to inpatient substance use treatment, and a lot of folks who receive young people when they're discharged from inpatient treatment. So back to you, Rosemary, and then I will bring up our next poll when you're ready.
Great. Let me just, hard doing these meetings on a phone. I got to start doing it on the laptop.
No problem. While you're looking, I can just say maybe folks want to jump in and say anything more about the type of services that you provide, or any reflections on this, what stands out to you about who we've got so far in the room.
Always happy to participate in the dialogue and kick it off. So Treehouse, we offer educational services primarily. So young students or students experiencing foster care, we connect them to either educational specialists or ed advocates, depending on their need. So that is a service that we provide to young people. I don't have the rest of the questions in front of me, but if there's anything else you want me to say, happy to, but otherwise I'll keep it short.
So I guess I'd love to hear people who do serve unaccompanied young people facing unaccompanied homelessness, but do not refer to inpatient mental health treatment. And is that a philosophical thing? Is that you don't experience the young people you serve as needing that level of intensity? And remember, when we're talking inpatient, well, this is mental health. We'll get to substance use disorder in a minute, I think. But yeah, I just love to hear that. That seems interesting to me, given it seems to be a kind of an epidemic proportion of young people needing support that level.
This is Vanessa Adams. I'm program coordinator at Kids Mental Health Pierce County. So in my current role, I facilitate multidisciplinary team meetings for Pierce County's Youth Regional Navigator program. So I facilitate these multidisciplinary meetings with complex young folks. I do not assess for inpatient anymore. They could possibly have recommendations to go to receive an evaluation. However, typically these are young folks leaving emergency departments, leaving inpatient hospitals, leaving juvenile detention, leaving other organizations. So they are at risk of homelessness. They are occasionally, semi-often, unaccompanied, or families that won't pick them up from these facilities, etc. So that's how I answered that question. So I am working with them. I'm not referring, if that makes sense.
It's more your role. Yeah, I get it.
Yeah.
I could say from Treehouse too, I think there is sort of like a moral dilemma of not wanting to put kids into institutions, if that makes sense. I don't think that as an organization, we have explicitly put thought into this, but like with ed advocacy, we support the young foster youth who are in night-to-night placements. And I'm sure there are needs there, but I think we want to avoid institutions as much as possible. And I think consequently that includes inpatient services. That's what I want to say. I don't know for sure. Like I said, I don't think we've talked about this out in the open, but I think there is sort of like just a gravitation towards avoiding putting kids into institutions.
Thank you, everyone. One question that I would like to ask to start off some discussions is, what do you feel has worked and has not worked? I'm sorry if I say your name, Tatya.
Tatiana.
Thank
So
you.
I'm just going to jump in and let y'all know about our SOC grant that we are piloting over here in Clallam County. We meet with folks before they're released from their system of care. We work with them after they're released to create that return to community plan. And we continue to have ongoing assessments and mentorship and case management, as well as that final return to community plan that they would support themselves without that case management.
I want to understand that. So if a young person goes inpatient, you provide support after they come back out? Is that what I heard you say?
Yeah, so anyone who has been touched by a system of care, so foster care, inpatient, anything like that, they are eligible for this grant service that is pretty comprehensive, very flexible, and set up to support them to not have to engage with homelessness at all, and also to just establish that community support that's needed to reintegrate back into society. So we've just started that with our local jail. We're also working with foster youth, and then we're hoping to branch that into our prison and our juvenile system as well.
Speaking from more of like the homelessness services lens here in Spokane, I would say what has worked well and what hasn't is probably the same answer: time. We've had a lot of success with the more like longer term community-based facilities, where we are given a referral well in advance before the young person's discharge date, and we're able to work with them. But kind of just the ongoing pattern with more of the acute facilities, more of like, I guess, maybe what you'd call like the hospital-like or institutional-like setting, is we're receiving referrals like after the youth's already been discharged or like 2 hours before. And at that point, there's really not a whole lot that my team and I can even do. And for one particular example, we had one time a young person was referred to us about a day or two before their discharge date. We had a referral submitted to IYHP, which is the Independent Youth Housing Program. It's transitional housing for young people with foster care experience. And they got accepted, but they exited the facility. We weren't able to get a hold of them. And so they didn't end up getting to go into transitional housing. And later on down the road, we ended up finding them in our young adult shelter. So I think that was like a perfect example of like, I guess I didn't really talk more about my program, but we're a supportive services program out in the community for unaccompanied young folks. But the sooner we're able to get to people and work with them on different things and different solutions, we're going to see a lot better of an outcome versus just discharging them into a shelter or discharging them into some other unstable situation in the community where they may just end up back in a shelter later on. So it's really frustrating. The more kind of acute care settings have been the most difficult. And yeah, it's the time piece and not receiving that referral soon enough.
It occurs to me when I worked at youth care, and I think they still have this contract, we had almost like an outreach worker / case manager who was in the juvenile detention facility that identified young people who are at risk of being, when they got released, being homeless, or the family wouldn't pick them up. I wonder if that's not something to think about with the inpatient programs as well, like somebody that's not there 24/7, but at least there's a relationship with staff, and staff could say, wow, it looks like Jim's going to be discharged into nothing. And then Jim can help navigate that program, meet the young person. I don't know. Do you have any thoughts on that kind of a model, Isaac?
Yeah, so that sounds really familiar to some of the projects that OHY already has. So there's, I mean, you're probably pretty familiar with the gym, but this system of care grants, and there's
Yeah.
specific like behavioral health ones. So for the team that I was referring to earlier, that's our InReach team working with unaccompanied youth. One of the grants that feeds that program is a system of care behavioral health grant. So we do have 2 case managers in Spokane that are specifically dedicated to those facilities and that are mobile. But it's just, yeah, it's just been the relationship piece with more of the acute care settings and kind of getting to understand the process, and that, you know, the shelters are there and like a young person might need to utilize them, but if at all possible, it should be a last resort. So it's really just like kind of changing that mindset. And it's just been slow going. And sometimes I wonder, like, I don't know, is it on their intakes when a young person comes into the facility where they're even asking, were you experiencing any form of homelessness, or do you think you might be at risk of experiencing homelessness upon discharge? Because oftentimes they're in the facility for a couple of weeks. If we found out early on, we would be able to know that and get in right away versus, you know, finding right on the discharge date.
That's a good question when it's on the intake form. You have some questions?
This is Ashley. I just wanted to add, I know on the adult side, it's a common question about housing and homelessness for screening for inpatient. I don't think that it's as consistent on the youth side, but I also do believe that units take into consideration housing and their living situation, and that can even be a barrier to admission. If they don't believe that you're going to have somewhere to discharge to, oftentimes that can even pose a challenge to getting into that unit.
Oh, wow. That makes sense, but I had not heard that. That is, so you get punished. You can't even get treatment. You have some questions, Rosemary.
And it just, sorry, I was just going to say, I mean, it just adds to my comment in the chat in the sense of some of these policy changes. I mean, it impacts some of the units' fear of having to board kids for months at a time if a parent refuses to come get them, or there's no alternative. So that is impacting their actual admissions criteria and decision making if they're concerned that they're going to have a youth in their unit that they're not going to be able to discharge once they're stable.
Yeah, no, I hear you. You have a couple of hands up, Rosemary. Karen, please.
I think just responding to like what's worked or what hasn't been working. I wanted to appreciate the comment Nicole was making around, you know, the federal funding barriers to housing, but for Team Child, which is a legal services office, we do legal advocacy for young people. We have historically for 20 plus, almost 30 years been called mostly by CLIP facilities, but you know, in the last 10 years also by the emergency rooms because the problem has expanded there, you know, for young people that are ready to discharge with no place to go. And the most common kind of case that we get is when there is the no place to go is related to a family situation where the family, you know, doesn't want them to come back to the house, right? And so there's sometimes some like overlap of like who's going to be legally responsible for them. Like, is the parent going to stay legally responsible? Are we going to put them in someone else's care? But that federal funding issue, my understanding historically was always that like the BRS level of alternative care, right? Like a group home that has behavioral, whatever BRS stands for, residential services, you know, that the only people who could go there were dependent youth. The funding flowed to DCYF. It was for a dependent youth. And so you couldn't tap a BRS type placement unless you were dependent. And a lot of the referrals we got actually were kids that had been in foster care, but were now adopted. So no longer dependent, no longer eligible for that BRS. So like, that's a to me, a kind of a little bit of a black hole that I think is related to what Nicole is saying about trying to address some of the federal funding that restricts the use of Medicaid to provide food and housing, basically for people, right? So BRS can use Medicaid for food and housing under, I don't know, some magic formula from the feds, right? So if you're a dependent, you can bill the Medicaid for the food, housing, and the mental health care under BRS, but you have to be dependent. But if you're not a dependent, none of the mental health providers can provide you with food and housing. So there's this weird circular problem of, so sometimes we would fight to get a kid dependent again so they could get the BRS level of care. Like whether they want it, that's what they didn't necessarily want to be dependent. They wanted the BRS level of care, right? They were willing to go through that. But of course, DCYF didn't want them to be dependent again. So that's I think one of the stickiest situations. I don't know if BRS level of care is a good level of care or not from like a therapeutic perspective, but it seemed like it was one of those gaps. Like we always called it the 0 to 60 miles per hour gap, right? You can have nothing or you can go to a CLIP facility, but what can you do in the middle? And BRS is kind of a middle. It's not a CLIP facility, it's more residential. I don't know if if that particular type of, intervention or treatment is a good treatment for young people in the situations they're in, but that's one of the places where we seem like we had the biggest barrier. And the other, which I know you're all aware of, and I know they're trying to address with some of that 1580 work, is young people who could, should, or would be eligible for DDA services, right? And then DDA seems to have a Medicaid waiver, right, to be able to provide housing. So either DCYF or DDA had the magic numbers to provide that therapeutic intervention with the food and housing, right? In a living situation that was therapeutic. So a group home, a licensed group home, an adult family home, whatever type of facility, the BRS homes. And so then the other reason why we get referrals is to DDA denied. We can appeal the denial, get them eligible, and then that doesn't always open the door for DDA. Then there's a whole nother level of fight with DDA just after you're eligible to get the services because you get on wait lists for the actual services. So those kinds of things to me are, and I think everyone, I don't think I'm telling you all something you don't know, but I think that to me, it's the 0 to 60. It's like, what do we need to have in the middle for, and wraparound was a response to that, right? To go home and then be able to be meaningfully held within your home environment and to have the family truly believe that there's enough support for them to be at home. Those kinds of things I think are really critical to being able to keep people from staying in psychiatric facilities or treatment facilities for too long. Getting after school and summer camp care for people who need a lot of therapeutic support. So one of the reasons why parents and families don't want to have their kid at home is they have to go to work, and they can send them to school in a special ed program from 8 to 3, but they might need someone to take care of them from 3 to 6, 5 days a week. And then they got 12 weeks of summer. And it's a young person with a lot of disabilities or a lot of different types of needs that needs a lot of support. And, the YMCA for the most part is not going to do it, right? Or Boys and Girls Club, it's just not a supportive enough environment. So I think those thinking practically about like what it means to do the long-term support of a family with someone who has chronic long-term needs. It means all those developmental stages. I mean, they might need support even when they're in high school. And we don't have that's why the DDA becomes an issue, but not everyone fits that box either. So I think it's those kinds of, how do you really support a family through the life of someone who has maybe a serious, prolonged, or chronic disability of some sort or health condition?
Well, I think what's true for me is what does happen after the inpatient experience, because we know there's nothing magical about that. In fact, I often tell parents, if your youngster goes into a treatment, mental health or SUD, that doesn't mean they're never going to drink a beer or smoke a joint or stop taking their meds. But my experience is what inpatient can do is, first and foremost, interrupt the pattern. So it gives the person an opportunity to have X number of days or weeks without drinking and smoking, with being on my meds. The second thing I've seen is it often, and this is why I think developmental programs are so important. You don't get this if you're 18, surrounded by a bunch of 50 or 60-year-olders. But if you're 15, surrounded by a bunch of other 15-year-olders who are wearing the same cool T-shirts and like the same music, then besides interrupting the pattern, you start to learn that, wow, there's some cool folks who have engaged with sobriety or have engaged with taking their meds. It's not this, I'm a weirdo because I don't do this when I'm in the middle of the public high school. And I'm not shaming public high schools, but And then the third is that opportunity, which is what breaks my heart, is to do that reconciliation with family and community. Like there are so many families that would come back to the table. But one of the families I'm working with, and this is different than the unaccompanied, this is the population Janice was talking about. The young person has caused $10,000 to $15,000 of damage to their house and another $10,000 to the neighbors. So they are like, hey, I love them, but we need help here. And so that's what I think the bridge could also be thinking about. And of course, I drink my own Kool-Aid way too much. Mockingbird family model, I think, is an example of where you can split young people up, but bring them together in the hub home when you want to have some group thing. But the whole group home model, the problem with that is it's always understaffed, and you typically bring people together based on the same diagnosis and the same developmental stage. So you sort of get a house of mirrors and not an opportunity to try different behaviors because you're surrounded by other young people who have the same behaviors. But I agree with you. I think, Karen, part of what you were saying, whether they're unaccompanied or with family, what's that step down and that community-based support when they do return to the community? Do you want to do one more poll question before we move into our agency spotlight? Do we have one more poll question?
Yeah, we have plenty of other questions, which we can always send as a follow-up. Would you like to do, what are the biggest gaps?
Yeah, that sounds
How do you
good.
support staff or
the young people
feedback?
wanted that. How do you support staff to support young people? Whatever that was closest to.
Great. Let me pull that up one moment. Great. So in this question, we were hoping to hear a bit about what all of your programs do to support staff to provide quality services, uphold your values, and avoid burnout. And I think here again, we're interested in knowing what works and what doesn't for your organization. Anything more you'd like to share about what your stated values are and any trainings that you provide?
And I'm just going to invite you to jump in. We've got a couple of minutes, and then Aaron, I want to make sure we save time for Aaron. That's a powerful comment from Ashley, and Gina endorses it as being a powerful frame and training. Moral injury.
Yeah, I would really encourage anyone on this call to look into that, and I'm happy to connect and provide the resources that we're using. But it's been a really interesting concept, particularly for people who are working in the behavioral health field and in healthcare. And it came really to the top during COVID and really talks more in depth. You know, we talk a lot about secondary trauma, vicarious trauma, but moral injury is really about the impact that we have supporting individuals in complex systems when we know they're not going to get their needs met, and the injury that it causes us as human beings. And so really talking about taking the time for ourselves to call that out and recognize that, and having the tools to help heal, right? Because so often we just want to move forward and continue with the work, and we don't do that when we have any other kind of injury, right? So just making sure that we're having the resources to do that. And it's been a really great training, and happy to share those resources.
Yeah, I'd love to get that content.
I think now would be a good time to open the floor for Aaron to do the agency spotlight.
Thanks, Rosemary. And the other Aaron, I think, is going to help me with tech here. It's nice to see a lot of familiar faces and new ones. I'm going to go pretty quickly today just because it's short on time. And I think a lot of y'all are fairly familiar with where I work. And thanks to Jim and Aaron for inviting me to do an agency spotlight. But just going to kind of jump right in. So I work at Legal Counsel for Youth and Children, or LCYC. And Aaron, I'm going to just prompt you. Next one. Just a brief overview of our mission. So Karen had already mentioned legal services. We are also a legal services agency that works with young people. And our mission is to protect the interest and safety of youth and young adults by advancing their legal rights. So there's a lot of different types of ways to support young people, and we specifically focus on legal services and legal rights. And we do that through direct legal representation of young people. We really try to focus on building strong community partnerships, like even being in spaces like this, and then systemic advocacy, which is like looking at all the issues that bubble up through our direct legal representation work and trying to figure out how to address it at a systems level. Next. This is just kind of a way that we visualize how we do our work. Again, the kind of strong community partnerships, systemic advocacy, and direct legal representation with young people being at the center of that. And we really try to commit to continually refining our approach, always be learners in this process. And so we look very often at the direct legal services that we're providing and the young people that we're reaching, like who are they? And trying to think about, is that matching what community's representation is? So if there's something that doesn't match as far as the demographics of the youth that we reach and who we're providing our services to, then we try and do deeper community engagement and deeper outreach work to make sure that young people who aren't accessing our services, we have to figure out why that's not happening. How do we make ourselves more accessible to the community where young people might actually need services? And we really value the strength and diversity of our partnerships. We have a lot of shared funding sources with community agencies, whether that be youth shelters, housing programs, behavioral health services. We've done a lot of kind of co-funded approaches, knowing that legal services is just one piece of a kind of puzzle. And so deepening those partnerships is always a goal of ours. And we really do want to, again, look at what we learn from young people and in partnership working with young people, what happens on the ground level in direct services, and then how do we turn that into actionable systemic advocacy. Next. These are the four main program areas that we have. So we provide legal services in child welfare proceedings, which is to dependent children and youth. We mostly do that in King County, although we're hoping to bring that to new communities. We provide representation in juvenile court for offender matters. We do some youth and family immigration work. This is mostly in terms of helping youth who have been abused, abandoned, or neglected, and who are foreign born, being able to get a state court action that then creates an immigration pathway for them. So again, speaking to our community partnerships, we work really closely with the Northwest Immigrants' Rights Project and other immigration folks who are experts in navigating that federal immigration process. And we do kind of the front end work to ensure that there's a pathway through state court to then access immigration relief for young people. And then our biggest program is our youth homelessness program. So this has been around now for a number of years, really piloted first, and then we did an evaluation, but providing legal services to young people ages 12 to 24 who are at risk of or experiencing homelessness, and in the broadest sense of terms, right? We're not, we try as best as we can, depending on funding, but to really have that doorway be really open and not have to be limited by, definitions of homelessness. Next. This is where we currently are working with young people and with community partners. So in King County, in Walla Walla, Thurston, Skagit, Clark, and Whatcom. And for the most part, when I think about those last ones, that really is our youth homelessness program. And again, speaking of community partnerships, that is done through the Anchor Community Initiative, working with partners on the ground to say, how can legal services support the work you are all doing through housing and behavioral health and all the other things that kind of anchor communities speak to. And again, legal services being a piece of it. And those are the communities that are kind of most recently been added to our youth homelessness program scope. Next. This is just kind of, again, a visualization of how we provide legal services to young people. We talk about holistic in the sense of serving young people in the best way that we can in both legal and non-legal needs, whether that's a referral, again, to a community partner that we work with. So not just staying limited to what we think, you know, here's the legal issue that we need to resolve, but thinking more holistically about it and supporting the young person and giving a warm handoff to other services. And again, providing community-based support. We've never had a physical office, so we've always viewed ourselves as like going to where young people are, whether that is the shelter, whether that's detention, whether that's a foster home or a library or a McDonald's, really going into the community to where young people are at, rather than asking them to come to us. And again, working with community partners to say, how can we support you in the work that you're doing with young people? Of course, being trauma informed and our commitment to anti-racism, a continual learning process, especially important knowing that most of the young people that we work with are disproportionately youth of color. And at the center of that is youth. So when we say we are representing young people, it's because they are our boss. The lawyers that are working with youth are directed by the young people. So it is what we call a stated interest model. The youth is the client, and the attorney is bound by all the rules of ethics around confidentiality and privilege. And their role is to counsel the youth and help them obtain the things that the young person wants to pursue in their life. And that is really how we work in our direct services model. Next. This is just kind of a general overview. We actually have a really cool tab on our website that talks about demographics. We have like an interactive tableau kind of thing, but just who we're working with. So roughly over 600 young people. We're in new communities, so that number will definitely change. We also contract the Office of Public Defense. We do what's called the Youth Access to Counsel line. A bill passed a couple years ago that said, anytime a youth under 18 is approached by law enforcement, that youth should have access to a public defender, essentially a lawyer, to counsel them on whether and how to interact with law enforcement, what to say, what not to say, what their rights are in that circumstance. And so that's been a new program that we've been implementing through OPD. And again, looking at our demographics, so close to 70% of the youth that we work with in those 600 cases, 600 unique young people, are youth of color. And close to 20% identifies LGBTQ, and 2/3 of them are under 18, whereas the 1/3 is young adults. Next. This is kind of the sample of legal issues that we might support young people in, whether it's access to public benefits, navigating landlord-tenant and other housing issues, again, immigration, juvenile defense, a lot of, in our youth homelessness program for minors, we say that a minor who is experiencing homelessness inherently has a legal issue because someone is legally obligated to be caring for that youth. And if they are experiencing homelessness on their own, then there is a legal issue to address. So with that in mind, navigating things like emancipation, child in need of services petition, potentially foster care. Sometimes young people do want to petition to enter the foster care system. And again, our attorneys guide and support them in that. And I'm just looking at Gina's question. Oh yeah, I can, maybe I'll send it to Erin Hathaway to share out with notes afterward, the law enforcement interactions. Technically, the law enforcement is the one to be required to initiate the call with the public defender. So the youth shouldn't have to do anything. The law enforcement officer should be the one initiating it, but happy to share more information about that program with Erin to send out in notes. Next. And this was just kind of a general slide. I think legal services as part of a homelessness response is a fairly new idea. LCYC again piloted it, I think in 2016, and did an evaluation. And again, seeing it as just a small piece of the puzzle, but really looking at the pathways to safety and stability, whether it's sealing a record that might help a young person access housing, whether it is filing a domestic violence protection order that would help them find a safe place to live, or an emancipation, or navigating landlord-tenant stuff, right? Those are legal issues a lot of times that you unfortunately probably need a lawyer to help with, but they are that pathway to a more safe and stable living environment. We also are really committed to building what we call legal literacy. So making sure that the kind of legal system and the words and the pathways are more accessible. We have a bunch of videos on our website, and young people have informed what videos to do and how we should do them. So it's a very youth-driven process. And also just building legal literacy in terms of, and I've got some slides here, I won't go into them, but just kind of like visualizations of what are young people's rights, what are their, again, points of access, what can they consent to, what they cannot consent to. So legal literacy is kind of those visualization tools or videos that hopefully help build knowledge around legal issues. And again, that coordination with agencies, our work in the anchor communities is kind of speaks to this, but being a piece of the Housing Navigation, Behavioral Health and Flex Fund legal services is one of those things that we think is critical to just have as part of like option of services. Next. And just a real quick note on systemic advocacy. My role at LCYC is Director of Policy and Systemic Advocacy. So again, looking at the fact that we exclusively focus on children, youth, and young adults' rights and legal interests, and we work across multiple systems, child welfare, juvenile court, immigration, homelessness, and we also work in multiple jurisdictions. So trying to elevate patterns and themes that we're seeing, that young people are saying they're seeing, and elevating it to advocacy coalitions and other spaces, and trying to change, whether it's law, policy, or procedure, or practice change, really trying to inform that based on the experiences that we're seeing on the ground. Next. And this is some recent highlights. Again, our youth homelessness program has expanded in recent years, which is really exciting, in partnership with all those folks in those communities. There was a bill that passed a number of years ago that says youth in the dependency and the foster care system should have access to an attorney. So we're trying to figure out how to build out our model, partnering both the youth homelessness program and the child welfare program. So again, speaking to the holistic nature, but also just making sure that youth have access to legal services, whether they're in a system or not in a system. And we have those dashboards on our website that just, we want to be really transparent about who we're serving and what issues those young people are encountering. And we're really trying to expand that special immigrant juvenile status work. We've seen a lot of young people really, if they do not have immigration relief by a certain age, they can lose that pathway altogether and potentially face deportation. Next. And we're not going to dig into this. I can share this with Aaron, but this is an example of kind of a legal literacy tool, right? So kind of a scan of what legal needs a young person might have that a community partner can kind of go through and check, whether it's a safety issue, education, public benefits, employment, and then referring them to LCYC if they feel like that young person wants to speak to an attorney. So just an example of a legal literacy tool that we use and that we use with our partners, especially a lot of shelters that we work with. Next. And this one, Aaron, we can scroll through pretty quick. Another example of legal literacy, but just a chart that talks about the things that minors can consent to. And this has changing, every year it seems like there's changes to this, but whether it's enrollment in school or leases or employment agreements. And of course, healthcare is a big one. We've got actually a separate healthcare chart altogether, whether that's substance use disorder treatment or accessing mental health, inpatient or outpatient. So that's a tool that we've developed, again, just kind of visualization of legal literacy. So I know that was a lot, short in time, but this is just a chance to provide a very high level overview of LCYC. And the last slide, I'm happy to answer any questions you might have, but the last slide also has our referral for our website. So it's lcycwa.org/need-help. And we can definitely provide, share these out afterward. And my email address is there as well. So sorry to talk so fast, but any questions?
Thank you for showing us this, Erin. Jim put in the chat that Jim, do you want to say that?
Yeah, thank you, Aaron. And just a reminder that if others are willing to do an agency spotlight or have ideas for a training, and I will contact Brian Foster. That sounds like an awesome one. But that's kind of what we're doing. We're going to have a retreat with Rosemary and V and others to kind of map out some of what we want to do. So please do let us know if you have ideas on trainings or people, agencies or systems that we should be connecting with. But I think that's it, Rosemary. We got Aaron's closing poll.
Yeah, I'm your poll driver today, and let me pull that up. This is just to make sure that anyone who might be eligible for a stipend has a chance to respond, confirm your attendance, and let us know about your eligibility. So please take a moment and respond to that if you think you might be eligible for a participation stipend. And I put in the chat, but I will say again out loud while folks are taking a minute to respond, we'll be sure to share resources that Aaron provided with the group afterward, as well as notes. We did record this meeting today. We'll make that available should you want to share it. And please be on the lookout also for any remaining feedback questions that we have to ask you.
Great. Thank you, Aaron.
Mm-hmm.
Now I would like to adjourn the meeting. So I want to thank everyone for being able to join us. I know that there are some people that have left already, but we're very thankful for all of you working with us on this project. Oh, and be sure to look out for the feedback survey that we'll be sending out.
Thanks, everybody.
Thanks all.
Thanks,
Bye.
Rosemary. Thank you, everybody.
Thank you.